Hi, this is Tammy. I am presenting my benign GYN case study, and it's history of present illness. Molly is a 30-year-old gravida zero presenting with complaints of irregular periods and pain to her lower abdomen and lower back radiating into both legs. Her pain starts the week before her menses and then subsides a few days after her bleeding starts. Her menses are heavy and she passes clots. Occasionally, her pain is so severe she must miss work. She is sexually active with her fiancé and uses condoms. She reports many years of dyspareunia, which seems to be worsening. She denies history of abnormal PAPs or sexually transmitted infections. Chief complaint: painful, irregular, heavy periods with clots so severe she misses work occasionally, along with worsening dyspareunia. Subjective data: medical history: she does have iron deficiency anemia. Medications are multivites and vitamin D. Questions to ask her: when did her menses begin? What does the cycle look like for her? How long does it last? How many days between her periods? How many pads or tampons does she go through? How long has she had the irregular periods? Were they ever regular? At what age did she become sexually active? Has she always had dyspareunia? Does Molly experience perimenstrual tenesmus, diarrhea, or constipation during her menses? Does she have painful defecation during menses? And is her dyspareunia worse during her period? Does she have dysuria, hematuria, nausea, distension, and early satiety? Is she taking any OTC medications or any herbal supplements? So her surgical history is a tonsillectomy and wisdom teeth extraction. Social history, questions to ask her: at what age did she become sexually active? Has patient ever tried to get pregnant, or is she experiencing infertility? Has patient ever been on birth control pills? Why are she and her partner using condoms versus birth control pills or any other form of birth control? Her educational level: what does she do for a living? Does she smoke? Does she drink alcohol? Is she depressed, or has she ever been depressed? Has she ever been in counseling for this problem? And what is her diet like? Excuse me. And then I would ask family history, any history of a first-degree relative with endometriosis. We've read that a woman with a first-degree relative with endometriosis has a lifetime risk of the disease, approximately 10 times that of a woman without an affected family member. Objective data: we're going to do a pelvic exam and ask her, is she tender? Do we feel a pelvic mass? Is her pelvic organ immobile? Any rectovaginal nodules? Uterosacral ligament nodularity? Does she have any bilateral fixed tender adnexal masses? Does she have a fixed retroverted uterus? Labs: I want to do a CBC, checking to see if she's anemic now. A CMP, baseline for liver and kidney health, and that's for the medication that I would prescribe. Blood sugar and blood protein levels, fluid and electrolyte balance, and also checking her metabolism. And then an HCG. Endometriosis may increase her risk for pregnancy and delivery complications. Plus, before we start meds, we want to make sure that she's not pregnant. Differential diagnosis number 1 is endometriosis. Pharmacologic: I would prescribe her danazol, initial dose 200 to 400 milligrams orally per day, given in 2 divided doses, and then a maintenance dose, just a gradual downward titrations to maintain amenorrhea. Duration of therapy: it can be up to 9 months. Non-pharmacologic: pharmacologic, naproxen as well, 500 milligrams PO initially, then 250 milligrams POQ 6 to 8 hours, not to exceed 1250 milligrams per day on the first day, and then the subsequent doses should not exceed 1,000 milligrams a day. Non-pharmacologic would be, sorry, I printed this out and it's like it didn't come out printed out well. Anyway, to adopt healthy lifestyle habits regarding exercise, sleep, stress management, and diet. Encourage her to eat more tuna and dark fish and not as much red meat. And then diagnostics. Diagnostic lab would be needed to be done. Education: danazol needs to be started during menses, along with obtaining a negative pregnancy test, and needs to be taken each day for at least 3 to 6 months and up to 9 months. Continue to use condoms for birth control. Tell her that naproxen should help with her pain. Explain the diagnostic gap to her in detail. Discuss the risk, which could be bleeding or injuries to nearby organs. Anesthesia complications are rare. Discuss the recovery process. She might have neck and shoulder pain from the gas, mild nausea, pelvic discomfort at the incision site, mild cramps, and mild vaginal discharge. She can shower in 24 hours, return to normal activities just whenever she feels able to do so. Review signs and symptoms of infection and explain to the patient how to keep the incision clean and dry. Explain to the patient what endometriosis is, and then referral to the Endometriosis Association, Resolve, and the American Society for Reproductive Medicine. Refer to counseling also if needed for depression. And then follow up 3 months to assess incidence, severity, and cycles of pain, dysmenorrhea, and dyspareunia. Review side effects of any medication. Ask about the issue of pregnancy, and provide emotional support and encouragement. And then differential diagnosis 2, adenomyosis. Pharmacologic, I would give her the LNG IUD. It has a variety of non-contraceptive benefits, including treatment for menorrhagia, endometriosis, and endometrial hyperplasia, which is what treatment for the adenomyosis is modeled after. And then I would also give her naproxen, 500 milligrams PO initially, then 250 milligrams PO, Q6 to 8 hours, not to exceed 1250 milligrams per day on the first day. Subsequent doses should not exceed 1,000 milligrams per day. And then for non-pharmacologic, I would just encourage her to, once again, adopt a healthy lifestyle regarding exercise, sleep, stress management, and her diet. I would also encourage Molly to get counseling regarding this diagnosis. Diagnostics, I would do bimanual examination and an MRI and an ultrasound. Education, would talk about the LNG IUD, and then tell her that naproxen will help with her pain, explain why we're going to do a bimanual exam and that we're looking for an enlarged symmetrical uterus, and that we can also do a 3-dimensional TVU or an MRI. Let her know what adenomyosis is, and let her know that also there are surgical interventions that can be done, an adenomyomectomy, a hysteroscopic endometrial ablation, uterine artery embolization, and lastly, we try to avoid is a hysterectomy. Referral to a gynecologist if increasing pain or bleeding occurs. And then follow up. If medical therapy is the initial treatment of choice, then she'll need to be evaluated in 3 to 6 months. And then I will be adding signs and symptoms of endometriosis to my pocket guide this week. Thank you. Y'all have a good night.